Good afternoon, everyone, and welcome to the last grand round of 2024. My name's Tom Ford, and I'm chair and organise grand rounds. And just like to thank everyone for joining, and thank anyone who's taken part in grand rounds in the last 12 months. It's, believe it or not, the 11th year that I've been coordinating grand rounds since Ron McWalter left. He used to organise the medical rounds, and most people in the audience will not have a clue who that was, but some of us are old enough in the tooth to remember Ron. So it's been my privilege to organise these grand rounds for the last 11 years, and we're still going as we move into a next quarter of a century. This week we have Heidi Douglas and Kalpana Ragapathy, who are going to speak about adverse event in cervical screening. Kalpana has spoken at grand rounds many times. She's a regular here with us, updating on cancer, obstetric, gynecology services, and it's always a pleasure to have her back. And I can always rely on her to volunteer to pop in and give a talk. Not heard from Heidi before, but she is, as it says on the screen, Associate Director for Public Health. So I'll not steal their thunder. They're going to talk about a screening process which Dundee, I think, is first in the country to complete, and it's going to give us some information about adverse events in cervical screening. Thanks very much for coming along. If you're not talking, please mute your microphones. You're welcome to leave your cameras on. If you've got a question, please put it in the chat, or we will get to you at the end. Thanks very much. Heidi, you going first?
I am going first. So I've got the easy bit because I'm just doing a bit of the scene setting and the context, and I'll hand over to Kalpana, who'll talk through the next stages and the hard work that is ahead of us in terms of implementing the learning. So as Tom said, I'm Associate Director for Public Health, but I'm also the lead consultant in public health for all 5 of the adult screening programs. So I'm kept super busy working with some amazing people in adult screening, but I'm also chair of the Scottish Cervical Screening Programme Board as well. So let's go back to kind of 2020. So we were just kind of coming out of that kind of the first COVID wave, and what emerged from our routine cervical cancer invasive cancer audit was that in one health board they'd identified a very small number. So I am using under 5 to describe small numbers, so some data suppression, individuals who'd had a diagnosis of cervical cancer, but also had a no cervix exclusion on their records. So the NICA, or the National Invasive Cancer Audit, is something that every health board does routinely. So the standard is within the first 3 months of a diagnosis of cervical cancer, a multidisciplinary team sits around, reviews the kind of individual's records, and also looks at their screening history, rereads any slides that have gone to cytology. Both want to kind of ensure the quality of the screening program, but also to identify any learning, but also to identify, if we've made any mistakes, and then applying duty of candor as well. And it was just through one of those routine invasive cancer audits that one of the health boards identified this. Now, the no cervix exclusion is ordinarily applied following a total hysterectomy. And what emerged through the kind of ongoing investigation as a result of those individuals was that actually their cervix had not been fully removed, and they'd actually had a subtotal hysterectomy. So the first thing was to look at, well, where could that error have actually kind of occurred across the screening pathway? And the screening pathway, for cervical screening, is a very complex pathway. So I think that was one of the first issues. But also, each of those purple points are points where errors could have happened. And in the words of one of our lead, fellow gynecologists in another board, and this really sticks with me around looking for the solution, was actually some very clever people made mistakes. So actually the solution to this was not going to ever be easy or straightforward. The stage one, so there are a number of stages to this adverse event. So an incident management team was established to look at the processes that we need to have in place in order to really kind of identify anyone who may have been excluded in error. So stage one, so across Scotland, there were 1,500 individuals who'd been identified with a subtotal hysterectomy code, SMR 01 or 02 code. So how that translated for Tayside was we first looked at those who'd had a total hysterectomy before 97, and that was very much a cut-off around risk and around time of exclusion from cervical screening. And what we identified was 72 individuals. We then looked at everyone who'd had a subtotal hysterectomy post 97, and that was 82 individuals. And then the final group was anyone who'd had any type of hysterectomy, an obstetric hysterectomy that was within 30 days of giving birth. And for Tayside, that was 8 individuals. Now, the methodology for reviewing these records was that we had Kalpana, Vimla, myself, core recall, colleagues from pathology, reviewing very much in detail the records for all of these individuals. And what we were looking for was 2 independent pieces of evidence that would either confirm whether a person had been excluded correctly or incorrectly. Where those 2 pieces of evidence didn't exist, or where there was inconclusive or mixed or no evidence, the next stage was to offer those individuals a gynae outpatient appointment to do an examination, a visual examination, to see if there was a presence of cervix. For Tayside, from that big cohort, we identified 7 individuals that had been excluded in error. So 5 were still in screening age, so they were reinstated. We had less than 5 that were had inconclusive evidence, but also I think, and this was one of the big challenges, was that nationally the earliest subtotal hysterectomy recorded actually was in 1959. So we were doing a very long look back at evidence. And this just captures, so for everyone that was kind of excluded in 10 years, in kind of 20% of them had been excluded within 10 years, but the majority had been excluded in kind of over 10 years. And for a smaller group of individuals, they'd been excluded for more than 30 years. Then there was the issue of the age profile. So we very much, anyone who was still in screening age would be reinstated if they'd either been excluded incorrectly, if they'd been excluded incorrectly. And so what we had for everyone that was still in screening age, half of the evidence was still over 10 years old. And obviously for those that kind of had been excluded for more than 10 years, that had been excluded and were out with screening age, 90% of the evidence was 10 years or older. So a lot of the secondary care clinical systems just didn't have the information in that we needed to make the decisions. And then stage 2, so this was all about risk management. So then the next cohort, which was the much larger cohort, it was estimated to be in the region of 200,000 across Scotland, was to review the records with a group that had any hysterectomy coding against SMR 1 and 2. And unfortunately, there had been a further death at that point. So what we needed to do was very much implement the learning from stage one. So for the total of records that we had for Tayside, having that very small multidisciplinary team and that expertise in the room, looking at every individual, absolutely worked. But when we started to think about, well, how is that going to work when we're thinking about 200,000 across Scotland, and it was 10,000 for Tayside, was, well, we can't, there isn't really the capacity to do the same thing. So we really needed to streamline the process. And that was the task that we kind of really took on board in NHS Tayside in terms of implementing the pilot. Also, what we learned, it was that if we were going to streamline the process, was that we really need to have an agreed set of definitions of what good evidence looks like, given the range, particularly the kind of the age range. Also acknowledging that a lot of the evidence didn't sit in secondary care clinical systems, so needed to think about what was available in primary care. But very much ethically, this was about how do we minimise harm, so how do we avoid over-intervention, recalling people back that didn't need to be called back, but also about minimising psychological harm, about being informed that you may have been excluded incorrectly and missed a number of screening rounds. And within this, we had the perfect storm occurring, i.e. we were also coming out of COVID recovery. So primary care was just getting back into the rhythm of providing cervical screening. In terms of our waiting times for routine recall from cervical screening, was not dissimilar to what else was going on in Scotland, i.e. we were in excess of the 8-week standard. So that capacity in terms of gynecology capacity was a real challenge. So what we did with Kirriemuir Medical Practice was we undertook a pilot to see, well, can we find a way of at least triaging and streamlining the process. So the first thing was starting with definitions, and these were the definitions that we used. So we kind of had the definitions in terms of what would be coded or what kind of evidence would be available for whole cervix removed, where the cervix remained, and the language where there was uncertainty. So just having hysterectomy or obstetric hysterectomy or abdominal hysterectomy or Manchester repair. So back to this question around, can we triage with certainty? So what we did, we had 112 individuals from Kirriemuir Practice, and we applied the existing standard around 2 pieces of evidence. And I think the key thing was that half of those, based on just looking at 2 pieces of evidence, required a multidisciplinary team. So that, although we were reducing the volume down by half, that was still, for Tayside, potentially 5,000 records. What we also noted was I suppose, because we were just at such a long look back with the changes, the clinical terminology, the interchangeability in terms of language and letters, who was signing off the letters or the operational notes, and also acknowledging there'd been changes in medical training over the years. So, what constituted a junior doctor will have changed. And so this very much, I think, generated more questions, i.e. what is the level of evidence required? And just as note, so for that, those 112 individuals that had a hysterectomy, only 3 had letters saying actually whether they should continue with screening or not continue with screening. So this is just, I suppose, the example of some of the evidence. Obviously, this has all been redacted, but so we're dealing with handwritten notes, sometimes some very poorly scanned, and letters that perhaps didn't actually have the name of the doctor that had signed them off. So this was the final, based on the pilot that we did, and this really informed the national audit going forward, was we really had really tight definitions in terms of the evidence, who could sign it off, and the language that absolutely had to be clearly described in each of those types of medical evidence. And the result was actually we managed to reduce, by having those new standard definitions, moving down to one good quality piece of evidence, we reduced that inconclusive group down from about half to 15%. So really using that clinical specialty, so that that kind of knowledge, and optimizing that in the MDT. And then we had the split around 40% were within screening age, and about 60% were over that screening age. So in terms of the next stage was very much to model, well, what does this all mean in reality, and where do we get the workforce or the capacity within the system to do the audit? So there was this notional 80-20% split around that tier 1 triage, so having kind of nurses and nurse colposcopists reviewing the evidence initially, and then where there was that uncertainty, going to that tier 2 complex MDT meeting. And then modelling from basically based on some national data around cohorts 3 and 4. So they were the ones that over 71 who would require a gynecological investigation. It was estimated that there would be about 830 individuals, and this would require 79 additional gynae clinics. And in Tayside, we were acutely aware that would be a huge challenge for us to provide that. And then in primary care, so primary care would receive everyone that was under it within screening age. That was estimated to be just under 1,500 individuals. So what we really wanted to do was actually take it a step further and think about, well, actually, can we improve on the national guidance? So we really focused on how can we reduce that inconclusive group, which was originally about 50%. We've managed to get it down to 15%, not only to provide better patient-centered care in terms of preventing unnecessary over-intervention, but also to make best use of our gynae capacity as well, particularly within the context of kind of waiting times for kind of non-routine cervical screening patients as well. And so what we did, although the national guidance was to not, we didn't need to review pathology reports, we really went that extra mile and downloaded and accessed those pathology reports as well to help us make that decision. And so what we managed to do in terms of particularly thinking about that kind of gynae demand was we reduced down from a kind of that estimated 79 additional clinics to 8 clinics. And for cohorts 1 and 2, so those that would require an examination in primary care, we reduced that from 1,500 to just over 200. And that, that I think is something that, and when we look at the national conversion rates, you can see that we're an outlier absolutely nationally, because we decided to put in that additional review step. In addition, we contacted everyone in cohorts 3 and 4, that gynae, to explain to them why they were receiving a letter, talk through the any concerns, and also to book them onto a gynae, one of the gynae clinics as well. It very much was a team effort, so we had just under 1.5 band 6 nurses, and as I've referred, including nurse colposcopists. Given that the challenge was to kind of make best use of our resources, we were kind of allocated an additional half time were band 7 as well. We had a program manager. We had 3 obstetric and gynecology consultants. Obviously, got Kalpana and Vimla here, and Laurie's. So Vimla and Kalpana undertook their MDT, and Laurie's reviewed and kind of supported the clinical intervention. And then there was myself, and we also had a project officer who kind of, I think, managed us all and kept us all on track as well. But the outcomes were that, you know, we kind of reviewed an extra 1,400 set of notes. We absolutely had a high level of certainty around those that had been correctly or incorrectly excluded. We had the lowest number in respect to those conversion rates in terms of people that did require, you know, an intimate and invasive examination, either in primary or secondary care. We had the highest uptake in terms of those taking up the examination in primary care. And we also, because we'd done that telephone contact, we had the lowest, you know, kind of number that needed to attend secondary care. We absolutely, I feel, reduced potential harm in terms of over-intervention. We shaped the national audit process because all of the work that we did in the background, and we managed to complete within the 12 months. So it was very much kind of job done, great. However, the job is never really done because there's always learning. And what was going on in the background was Health Improvement Scotland had undertaken an independent review and had established a number of recommendations, which included having an established QA process ongoing to ensure that we learned from this mistake, but also we could flag any potential errors in the future. So in some respects, although we all kind of undertook a collective sigh of relief when the audit was finished, but in some respects, the hard work does very much start here because we need to start to implement and embed the learning. So we have conducted a mini audit just to get a kind of sense of where are we now, and very much we're not quite there. Things have improved massively, but we're not quite there yet. We need to have that standardized approach where we clearly record the type of hysterectomy, but also communicating the importance of why we need to do that. As standard, also communicate this to patients, including whether they should continue or not continue with their cervical screening, and have that ongoing QA process in place. So we have the confidence that we have learned, and we're also continuing to seek opportunities for improvement. So that's the end of my bit, and I'm going to hand over to Kalpana now, who's going to talk through the next, I think the next stages, and I suppose I've very much presented this from the public health perspective as well.
Heidi, could you share that slide, where there's a photo of the team?
Yes, I sure can. I will do that. And I'll see if I can go back. There we go.
I can't see it as yet. Oh, it's just coming. Yeah. So just wanted to point out that, these are the lovely nurses at tier 1. Vimla and me are the non-glamorous part of the team, so we are not in the photo. We thought we should Photoshop ourselves and then decided not to spoil the photograph. Okay, so I'll go to my presentation now, Heidi. I'll share my screen. Current share, and hopefully entire screen, will it work? Let's see. Is that working?
Yes.
So thank you, Heidi, for setting the tone. Vimla and me were the audit leads for the no cervix national audit that we were undertaking in our own Tayside regional board. So this was just to let you know what were the challenges we were having and some observations we have made along the way. When we got to know, so at one point when I think Heidi showed you that initially we undertook audits on subtotal hysterectomy first, even before we started the national project. And the first time the audit was done, I was the culp lead. The second and the third, Vimla was the culp lead. So we had some kind of experience already in these in that kind of an audit, but it is just that the numbers was much smaller, and we were going to undertake an audit of about 10,000 odd patients. The good thing is we did get paid for this. It was not an unpaid position. And we thought it's not a difficult job. It's just that we need to be sure that the no cervix clause was applied properly. And the individual has been ceased from recall quite appropriately, and there was no problem with that. And we were absolutely naive to think that that was quite straightforward, because we have a tightly packed Monday to Friday schedule as such for cancer care. We had to have a discussion with our senior management, and they agreed for us to take this as a secondment, as a short-term secondment. So we decided Saturday is the one day that we can provide, because it's our own time, and we will not be endangering any of our clinical care. And usually that's my Saturday. Multi-slacking is a word that I love on a Saturday, but then the Saturday became the new blue Monday for us when we were doing this project, because come Saturday, we would be going through all the archival records to find out the information that we are seeking. So the challenges that we had at tier 2, so the nurses that you saw on the photograph were the tier 1, and they were absolutely fantastic. So they would screen the records first and then decide if they have enough information available. And it was very set in stone, that criteria. If that satisfied the criteria, they were able to say in that level itself that the individual was rightly ceased from call recall, and that doesn't need a review of record. But the patients, the individual flagged up to me and Vimla were quite challenging, because they were not straightforward. The information was lacking. And we also had to audit a certain percentage of tier 1 reviewed work. So these were the challenges we had. One was information gathering, information processing, and third was the changes in the screening program, because we were going back in years quite a bit. I think the earliest we had to look up a record was in early 1970s as part of this project. So we had to keep in mind that the screening program has also changed, has evolved with the years. So always we had to put ourselves back in which year it was, what was the screening program then, would they have taken the decision to cease at that point in the screening program. So those were the difficulties we had. So for information gathering, the most straightforward was if we had access to notes. Unfortunately, Tayside does destroy the notes after a 12-year period, so we didn't have access. So we had to then pan out. Colposcopy records, we are one of the very lucky units that we still keep colp records out with the general notes. So if ever a patient has attended colposcopy in Tayside, we still have access to this record, and we have held on to it. We have it started for a different reason, but it really helped us for this project as well. ACUS is quite it is a smear system that was in place before the new SCRS came. SCRS is the now computerized call recall system that just sends out the invite letter to every individual needing a cervical smear test. But we went back to the legacy database as well. Lab Center is the old pathology database that we dipped into. We looked at clinical letters, obstetric records, and more recently it was ICE and clinical portal. Once the individual's screening decision came to the late 2000s, it was much easier for us because we could just look up ICE and portal. And we did dip into the SCRS I've already spoken. NICAS is a national colposcopy database that we had access. So we had to score through all these databases. Now, I put the picture of Lab Center. I don't know how many of you are used to the system called as the PASS. The PASS is a very, very old system of computerized filing. It's like using the very first phone, like, like a brick there. This was, I think, the oldest of the mobile phones there. So where we are now in a system that, our phones are like smartphones, and the new, like the portal, the ICE, the track are all quite sophisticated. We had to go back in time, and we needed to have a learning session by itself, how to navigate the system. You could see that, I've highlighted. So say, for example, you wanted to see the next result. You don't just click the arrow button, you have to put capital N and R together. It might sound simple when I'm saying this, but now, because all the systems we are working with are so intuitive, to go back in time and to navigate through another platform was quite challenging, but we did that. And if somebody else has done PASS before, all I can say is you're ancient in the healthcare system. We are all getting quite old if we have used this. So next was the information processing. So we had to look for surrogate markers. So, just to make a point, the tier 1 reviewers would have already said that the individual has been cohorted properly if they had the information. If the information was not concrete, then they were coming to us. So we started looking for surrogate markers. Say, for example, somebody has had a hysterectomy like 10 years before, but subsequently they've had a gynae appointment. And in the gynae appointment, an experienced gynecologist has said the vault looked healthy. Then we took that as a surrogate marker that it was a total hysterectomy that had been carried out, because otherwise the gynecologist would have said the cervix has been present. We reached out to radiology colleagues and we said, look here, we are doing this, and a patient might have had like a MRI scan for something else, like a fracture of a spine or anything. Then we would ask, could you review the scan and see if there was any cervix seen post-hysterectomy? So we kind of put all our clinical expertise to look for these surrogate markers. I think we were the first board to establish that we need an MDT meeting. Once every 2 weeks, we brought these complex cases that we couldn't take a decision. We wanted to put it out to the bigger team to say that, look here, we have reached out, we've done this, we have done this. Should we be saying that it is okay to see this person, or should we be bringing these patients back to clinic? So I think this was one of the good practice points that other trusts then picked up. We did want a national MDT as well. So the cases that we couldn't take a decision locally, that we can reach out. This never got formally done, but we did reach out to other colposcopists informally to find out what is happening in their boards and try to take a decision as uniformly as possible. Credibility of documentation is the other thing I really want to touch upon. So the decision by the national team was that they've got to be a senior doctor who has written the letter to say a total hysterectomy. But when we went back in time, we saw that, a senior house officer would have done the documentation, but senior house officer of yesteryears is not the same as senior house officer currently. It's because the training system is different, the experience is different. So we had to look for signs on the letter to see how experienced this person is. And what are the markers we used? It would be, I'll show you some of the letters, very elaborate letters saying what was the finding, what difficulty they had in the hysterectomy. And then if they said total hysterectomy, even if they are a senior house officer, we accept it as a piece of evidence, because we could find that, we could find obvious evidence that they were far more experienced. So we had to go back in time again and put that in place. There were some sensitive issues we came across. A few of our patients, unfortunately, are undergoing cancer treatment for something else, not for cervical cancer. We didn't think it was appropriate. We send these standard letters to them to say, oh, we have screened your record. You're not at risk of, you were appropriately ceased from cervical screening program. So we took the letters, we redacted the letters and wrote a personal letter to the patient so that they are not too worried. We picked up few issues where I remember vividly one of the patients were rightly excluded, but they had had a hysterotomy for a termination of pregnancy, and it was really complicated. They had to have a hysterectomy. Even going back in time, even now, I think it would be very sensitive for the patient, for the individual to be reminded what a traumatic time it was. So for those individuals, we did alter the response we were giving in a very sensitive way. So next, I told, the screening program has evolved. So we had to just make sure that, we were taking the decision properly. I think most of you would be aware the screening age has definitely changed. It was 20 to 60 before, and now we are offering between 25 and 65. When we were almost 1/4 of the records, we realized, why are these patients on the no cervix audit clause? So what has happened is they've had subtotal hysterectomy, and they continued to have smears, but until their age of screening finished, and then they were discharged. But they were coming under this clause. So we noticed that there was an error in the way the query was constructed. So we went back, and the national team rectified that error, and then we restarted. So we paused for a few weeks when that was happening. But I think our board was the one to identify that. Again, Heidi can correct me if I'm wrong. And the initial practice when we started off with the screening program, even if they'd done a total hysterectomy, some patients were, the practice at that time was to bring back individuals for vault smears, which we don't do anymore. But we had to go back in time and piece the things together. So we looked up some of the literature where previous screening program has been discussed. We went through archival documentations of the screening program drafts. And then we decided, okay, that's fine. They have gone from the old system to the new system and then got discharged appropriately. One thing that did catch us is Manchester repair. Manchester repair is a prolapse surgery where if there is an isolated cervix prolapse, they would take away almost the whole of the cervix and just leave the uterus be so that there is no prolapse anymore. This is not much carried out these days because we have more fancier operations. But the practice at that time was if somebody had Manchester repair, they would be discharged from call recall. But it took us a bit of time to work that out. We actually reached out to one of our cytologists who has long retired. But that's the beauty of Tayside again, that we are small enough and big enough at the same time. So we had contact details. We reached out and they said, oh, absolutely, Manchester repairs at that part of the screening program, they were discharged, and they would make sure that the internal loss and external loss was represented in the pathology sample. So then we took a decision, okay, all Manchester repairs can be safely ceased from screening program. So those were the challenges, as I said, the information gathering, processing, and making sure that we are in line with the screening program for that particular year the individual was ceased. But some interesting observations along the way, because even though we were doing this as a audit process, we were still looking at some of the clinical things over the years. It has been an absolute privilege actually to go back in time and look at the practices. So this was in 1986. A registrar has done the abdominal hysterectomy, so there is no consultant overseeing this. The chance that this happens right now is negligible because we are doing lesser number of hysterectomies, and more often the hysterectomies are complex. Our training system is very it's quite streamlined because a trainee starts at ST1, finishes at ST7, but to do gynae surgeries like a hysterectomy, they come only in the last 2 years. So even the senior most trainee will have the consultant hovering around when they're doing a hysterectomy. Okay, and this was my own letter that I saw from 2014. That was when I started as a year 1 consultant, and I have been very worried. And I've said, for endometrial cancer, I'm going to do your surgery, but her body mass index is increased and is 33. Now we are offering hysterectomy up to a body mass index of 62. So in the last 10 years, my practice has changed, and I don't think I comment on letters if the BMI, as long as the BMI is less than 40, doesn't feature in my letter. It's after BMI 40, I start commenting. So I thought it was interesting. The practice has changed and the population has changed. And there were some letters which has stood the test of time. This was from 1975, a very clear letter saying, we have done this cone biopsy and hysterectomy, and you're due for your smear test. And could you do this? Some interesting documentation styles. At operation, she had a tiny, innocent-looking uterus, and it's hard to believe this has been the cause of so much trouble. So there were worse ones I can't share, but we have found some communication styles which are like, oh my God, we can't do this at this study, at this stage, we cannot do that. And but just some interesting observations. And finally, when we hit the 10,000, it was on a Saturday again. I think I took this photograph and I sent it to the team. What a jubilation it was for the team. We worked together very closely for 8 months because I think we finished quite early on, and then we were just tidying up the process in the last 4 months. But it was, I think, the success was our tier 1 reviewers were fantastic. They gave us complex cases, but the number was not as huge. So then we could use our expertise properly. This was shared with the team, and everyone was like, oh my God, we reached 10,000. And we were the first in Scotland to complete the audit. So how many services did we finally find? Because that was the aim. Just to remind you, what was the aim of our audit? We found about 17 cases of cervix on a paper exercise. So ultimately, when the 17 individuals were called forward for a clinic appointment, either with the GP or for us, only 4 attended. I think Heidi has touched upon that. There were not that many who wanted to uptake the appointment, and some actually forthrightly declined. They said, no, you're not coming. Okay, and 4 attended, but even in that 4, we actually identified that there was no cervix, even though the paper suggested that there was cervix available. And there has been only 1 that we know of who was HPV positive. We have not picked up any cell abnormality in this cohort. Just to say that, I've always maintained this, our trust is small enough and big enough at the same time. And I think our screening program has been very robust these years because of the close association we have with the call recall office and the colposcopy service and the GPs. So it has been a success for Tayside. So going forward, this has already been implemented. Even when we started the project, we had already implemented. So there is a reminder in all our operating theatres, whether we are operating in Ninewells or in Perth, all the gynae theatres. So for the non-surgical audience, when we do a hysterectomy, we should usually fill up pathology form where we're telling what was the diagnosis, why we did the hysterectomy, and any difficulties in procedure. So there is a reminder there to say, you have to document total hysterectomy or subtotal, and whether the cervix was removed completely. So everybody documents that in the pathology form or expected to. The call recall office do get a copy of these pathology forms, and then they label not for further recall if they're satisfied that they have the necessary information. But the ultimate responsibility is the gynecologist who's doing the hysterectomy to make sure that the individual receives appropriate counseling about further smear tests. For this, the chief medical officer in Scotland issued guidance and a letter. Our clinical director shared it with all our consultants, and this has been, we have discussed this in a couple of consultant meetings since then. If the information is still not given, then the call recall office do get in touch with the consultants by email correspondence saying, look here, this information is not available. What do you want us to do with the patient? But we have also decided that we'll do an annual audit to be done to look for lapses, and the first audit will start in January 2025. So the only last thing I want to mention is there is one piece of information we didn't look for, but for that, I have to ask the card makers. When they say farewell to your uterus, they need to have a card that says, and your cervix as well. Okay, thank you so much.
Thanks very much. So that's a great piece of work. A lot of effort, a lot of time to come up with all that, and a good demonstration of cross-working with our public health colleagues. And a really important topic. We've heard you talk about cervical screening before, and obviously a topic close to your heart, and it's really great to have you back to speak again, Harpner, and to you, Heidi, as well. So any questions in the chat? I'll just load that up. Nothing is there. We've got any questions, any hands up to ask you a question? Doesn't look like it. Looks like we stunned everyone into.
Tom, could I also suppose we're very much focused on NHS Tayside. I know Kalpan has talked about, that cervical screening works across primary care as well, and we've got such good relationships with our GP colleagues. There was a big ask for like from GPs as well. So that tier 1 kind of triage review of records was based initially on what was scanned from GP records as well. So I suppose I don't want to underplay the effort that was also from primary care as well, because it was substantial.
Yeah, absolutely. I think we have some advantages in our shared information we get across primary care, but not everything. And in an ideal world, if you're building it today, it would be just one system, wouldn't it? But I know from my wife, who's a GP, getting all this kind of information is not straightforward, and a lot of work will have gone into that. Right, and in that time, friends of Grand Rounds, Sarah and Danny, have put their hands up. Sarah Alstoff, go Hawks.
Go Hawks, indeed. Thank you very much for an excellent presentation. Just if I understood it right, you identified people who had some kind of hysterectomy using coding. Is that just done with? Is that unique to Scotland? I suppose I'm thinking of my often transient and very mobile population of people living with HIV who travel a lot and move a lot. So if people have had some sort of hysterectomy outside of Scotland, will those be people who were not captured, or is that coded by GPs when they transfer their care? Would they have been identified or not?
So thanks, Sarah. So the practice is, if anybody has moved into Scotland after having a period out, their smear history should be updated on SCRS. So when you open our smear database, it will say transfer to Scotland or smear out with Scotland. And at that time, the GP has to update if they have had a total hysterectomy or subtotal hysterectomy. So it will get, if it is done properly, it should come through that.
But what we may not know is if they say, let's say they moved to us from England or somewhere, and they tell the GP they've had a hysterectomy, we don't necessarily know whether they still have a cervix.
Yeah. So it is the transfer of records. The GP should be requesting all the transfer of records. But what we did for this audit purpose, Sarah, because we could, reach out to other hospitals, like say, for example, somebody has had it in Forth Valley, and I'm not able to get any information through the tier 1, couldn't find any information. I've reached out to say, look here, could you look up in your lab to see, because we got Caldicot approval across Scotland for this, but we couldn't reach out to other nations like England and Wales. I couldn't do that. What we decided was, as long as we have evidence that in England or Wales, they had taken the decision to cease the program, we will not audit those. We will accept that because it was a different nation's policy, and there's clear documentation that they have ceased. And the only person who will have access to this is the GP, because they have transfer of records from England to Scotland. Heidi, did I?
Yeah, and I think it's probably important to note the English no cervix exclusion process is slightly different from the Scottish one, in that excluded from the English cervical screening program, you are written to say you have been excluded. This is the reason why. And if you believe that's not correct, to go to your GP. So there's a bit, so there's that extra fail-safe in the English system that isn't there that hasn't been there in the Scottish system as well, in terms of, so what we were finding when we were speaking to patients was they would go, oh yeah, I know what type of hysterectomy I had, and it happened here, whereas we weren't able to kind of get that from their records. So often a lot of patients said, and similarly we had patients who'd had their hysterectomy abroad. So and people who not only moved from England to Scotland, but moved from between health boards while we were doing the audit. So it was often, we just became super detectives, basically, hunting down every glimmer of evidence that we could, really, I think, and it was this avoiding this over intervention and potential harm caused to people with a letter saying we're not sure what happened, because that also potentially impacted on people's credibility in screening. So also I think highly attuned to that as an unintended consequence.
Thank you. That answered my question. Thank you.
And then Danny Chandler,
Thank you.
also a friend of Grand Rounds.
And a friend of Heidi as well. Heidi, I was kind of aware of the look back, but not the detail. So it was really fascinating. And Kalpana as well. Thank you for going through all of that very clearly. My question is about, at the start, Heidi, you talked about a relatively small cohort of people who had a code for subtotal hysterectomy and yet had still been excluded. Did you get under the sort of skin of what the error was for those individuals, or was it a mixture of things?
It was a whole mix, and that's that flow chart where we mapped out the potential, and that was done nationally as part of the national IMT, was mapping out where the errors had occurred. Because I mean, it would have been great if the error was at one point, because we would have just gone to that point in the screening pathway. But we soon found that it wasn't as easy as that. And that, I think that's made the embedding the learning. So the embedding the learning isn't just at one point, and we've got to have a number of points where we've got to ensure we get it right, and also to have that QA process as a check and balance that we have got it right in place. And I think it's just reflective of the complexity of the cervical screening program, and it's quite unique in that way compared to the other screening programs.
And just to add that, Daniel, we got a bit worried whether the code was applied right in the first place, because we started off from the code. So it's good that we have gone the other way rather than just concentrating on the code, because we did realize when we were auditing that the code was incorrectly applied. Like one of the individuals had a hysteroscopy, but their coding was applied as a hysterectomy. So it's good then that, we started with that 10,510 records rather than just who were coded as a hysterectomy or a subtotal.
And I think the other element was also about the I suppose the validity of the coding system as well. So when we looked at the obstetric hysterectomies, we knew just by the numbers that we were managed to extract nationally. So Public Health Scotland did all of the data extraction to identify. We knew that particular group was too small, just by doing some basic maths of how many obstetric hysterectomies are done every year. So we knew that was too small a number to really reflect. And that was really one of the other drivers to do that larger group, because we would catch those women in that larger group. So that final stage of the audit. Right.
Thanks very much. It's 5 to 2. I think folk have clinics and other things to get to at 2 o'clock. This wraps up the 2024 Grand Round programme. We've had a really varied programme throughout the year. A break for the summer. We've heard from almost every department and directorate that there is, from primary care, secondary care, from public health, from medicine, from surgery, from specialist services. And we're starting to fill the programme up for next year. There are still a few gaps. So if you're sat there on a talk thinking, I could really present at Grand Rounds, then please do let me know so I can allocate you a slot. Or if you know somebody else who gave a good talk that you heard recently and they could be tempted into a Grand Round presentation, then again, do let me know. Other than that, all that remains me to say is thank you to our speakers today. Thank you to all the speakers for 2024. I hope you have a great festive period, whether you celebrate Christmas or not, and a good new year. And I look forward to seeing you again in 2025. Thanks very much. Take care, everyone, and goodbye.